Good evening. Good evening, all. I welcome you all for this month's Journal Club. We are very happy to have you all on board. We have got few specialities for this Journal Club. We have something new this time. Every time we have been hearing to our revered international faculty from the US, North America. This time we have somebody from diagonally opposite location from Australia, Dr. Amit Khoth, who is who has got great work in the field of plasma cell dyscrasias. So we are happy to have you, sir. Welcome to the Image Journal Clubs. Today, Dr. Ranjit, who is a consultant hematologist at Command Hospital, Pune, would be presenting a very interesting article about the combination of carfilzomib, cyclophosphamide and dexamethasone and its comparison with transplant, followed by a consolidation therapy with KCD and maintenance with carfilzomib. So the role of or the efficacy of transplant in comparison to no transplant and only KCD will be discussed by him. Followed by that, we'll have some comments from Dr. Amit about the article and about its real life scenarios. And thereafter, for this session of Gen Club, we'll be having some introspection, some features, some comments from our a friendly neighboring country, Bangladesh, by Dr. Mohiuddin Khan, whom I will introduce at a later point of time. So without wasting any time further, I would request Colonel Ranjit to kindly present the Journal Club. Over to you, Colonel Ranjit.
Thank you, sir. So is my screen visible, sir?
Yes. You can put it on a viewer mode.
Full screen mode.
Full screen mode, please.
Is it okay now, sir?
Yes, please. Good.
Please go ahead.
At the very outset, I would like to thank Colonel Uday, who is my senior colleague here at Pune, for giving me this opportunity to present in this international forum. This is the place where I work. This is Command Hospital, Southern Command, Pune. And I'll be presenting my Journal Club on this wonderful article by Dr. Yong, which is done across the UK. It is upfront autologous hematopoietic stem cell transplantation versus KCD, that is carfilzomib, cyclophosphamide, dexamethasone consolidation with carfilzomib maintenance in newly diagnosed multiple myeloma patients. So what is the background to this study? As we all know, the landmark IFM 2009 trial, the EMN02 and the determination trial, they demonstrated a superior PFS for autologous HSCT. The common denominator in all these studies being Borges induction followed by Revlimid, that is a lenalidomide or IMiD maintenance. So the extended proteasome inhibitor post-HSCT benefits patients with high-risk disease, particularly in patients who are having deletion 7p. And the first-line therapy with carfilzomib, it induces high response rate and MRD negativity. So what is the role of MRD negativity? So surrogate for PFS is MRD negativity. So it has got a very strong prognostic value and has been incorporated as an endpoint in majority of the ongoing trials, that is with, as we know, anti-CD38 monoclonal antibodies, carfilzomib, etc. So it induces the very, the progression-free survival is very good with, especially with the newer agents. So MRD negativity with a sensitivity of 10 to the power -6, it is strongly associated with longer PFS and overall survival. So it is going to be the gold standard in the future to guide clinical decisions on autologous transplant, as well as the intensity and the duration of maintenance therapy in the coming years. So as we all know, this is a landmark IFM 2009 trial. Here we can see there was superior median progression-free survival where the VRD arm just had 35 months as compared to the autologous arm, which had 47.3 months. The other thing to note is the 8-year overall survival between the two, that the VRD and the ACT arm was almost similar. So the reduction in relapse or the death was by 35%, higher MRD negativity rate in the ACT arm, and there was no overall survival benefits. So there was a question, can a delayed ACT is feasible? So we need to explore further. So this is the Forte trial where carfilzomib was used as a first-line agent, and here we can see there were 3 arms, arm A, B, and C. So at the end point, I would like to just concentrate on this thing, the KRD12, the MRD negativity in the high risk, the double hit, as well as the sustained MRD negativity is very superior. So KCD consolidation was non-inferior to upfront autologous stem cell transplant in transplant eligible newly diagnosed multiple myeloma patient. However, the margin was very small. So by this trial, we can see that carfilzomib has moved into the first line agent for induction therapy. So what is the aim of this trial? It is to investigate any detrimental effects of allocating patients to a non-transplantation group using carfilzomib-based induction, consolidation, and maintenance approach. So efficacy of the triplet regime, KCD as induction in transplant-eligible newly diagnosed multiple myeloma patients are checked. And it is to evaluate the non-inferiority of KCD consolidation compared with upfront autologous HSCT in patients who are having a response of more than PR. So this is the methodology. It is a phase 2 open label multicentric trial. It was done across 19 hospitals in the UK, and the number being 281. It was registered under the clinical trials government, and the timeline was June 2015 to July 2019. And the data collection, the data cutoff was 7th July, and 2022 was the last day for data collection. So the inclusion criteria being adults who are 18 years or older, and ECOG performance status of 0 to 2. Performance status of more than 2 was permitted if it was due to disease-related complications. Symptomatic myeloma who are eligible for high-dose chemotherapy followed by autologous rescue, and measurable disease according to the standard criteria, and life expectancy of more than 3 months with adequate cell lines in the form of neutrophil counts, platelet counts, hemoglobin, and adequate decent creatinine clearance. So what were the exclusion criteria? So patients who were previously exposed to systemic therapy for myeloma, the exceptions being local palliative RT and steroids for a maximum of 4 days. And substantial cardiac comorbidity was excluded because, as we all know, the carfilzomib has got very high incidence of cardiac complications. So this is the trial algorithm. So the induction was with 4 cycles of KCD, the carfilzomib being initial for the first cycle on day 1 and day 2, 20 mg per meter square of the first cycle, followed by 56 mg per meter squares on day 1, 2, 8, 9, and 15, 16. Thereafter, in the remaining cycles. So the cyclophosphamide was dosed at 500 milligrams on day 1, 8, and 15 of all cycles, and dexamethasone 40 milligrams on day 1, 8, 15, and 22 of all cycles, followed by mobilization, harvesting, and randomization. So the randomization was done only in patients who had achieved a response of more than PR, and the randomization was done based on a computer algorithm from the UK Clinical Trials Group. It was randomly assigned to 1:1 to either a high-dose melphalan and autologous stem cell arm or a 4 cycles of KCD consolidation arm. Both groups received maintenance with carfilzomib. That is, all randomized patients received 18 cycles of carfilzomib at 56 milligram per meter square on day 1, 8, and 15. So this was the randomization. So let's come to the trial profile. 281 patients were registered. So 3 patients withdrawn, followed by we had a safety population of 278. 255 of them completed induction therapy. So during the induction, we had 23 patients who were withdrawn, 3 deaths, 3 progressive disease, and 16 patients had encountered different levels of toxicity, and 1 patient withdrawn because of his own choice. After the completion of induction therapy, we had 27 patients who had withdrawn. 1 death was there. 11 of them had progressive diseases. 6 induction responses were less than PR, and 5 patient choice and 1 clinician choice. 228 of them had stem cell collection, and subsequent to the stem cell collection, still 10 had withdrawn. 6 had progressive disease, and 1 was unable to comply with the protocol. 2 with intercurrent illness. So coming to the KCD arm, 218 were randomly allocated after the 228, out of which 10 had already withdrawn. So in the 218 who were allocated, 109 were randomized. That is a 1:1 equal randomization based on a computer algorithm. So 109 were randomized to the KCD consolidation arm, and 104 had started KCD consolidation. 5 discontinued treatment prior to starting the KCD consolidation. Then because of the progressive disease and toxicity in 2 patients, again, subsequently 5 patients subsequently discontinued. So 99 of them completed KCD consolidation, and 97 had moved on to carfilzomib maintenance, out of which 2 had discontinued because of progressive disease in one of the patient, and the patient refused to continue treatment further. So 2 of them discontinued. So the total figure in the KCD arm was 97 of them had carfilzomib maintenance, and subsequently only 59 could complete the carfilzomib maintenance because of intercurrent. As we all know, the COVID pandemic had started during that 2019, and 23 had disease progression, 5 had toxicity, and 3 had intercurrent illness. And 109 were included in the ITT analysis, and 104 for the in per protocol analysis. So coming to the melphalan and the autologous arm, Here it was equally randomized, 109 patients as compared to KCD arm. Here, 104 had undergone a stem cell transplantation with mobilization followed by stem cell transplantation, and 5 discontinued treatment because of death, toxicity, prolonged poor engraftment, and intercurrent illness. So the 99 were started again on carfilzomib maintenance. Only 55 could complete the carfilzomib maintenance because we had multiple issues post-transplantation. 1 had expired, and 15 had disease progression, 7 toxicity, and with intercurrent illness having 2, and some patients were lost to COVID. So 109 patients were included in the ITT as well as 104 in the per protocol analysis. So the follow-up disease response assessment as per the modified IMWG criteria, and the bone marrow examination 1 was done after peripheral blood stem cell harvesting, the end of KCD consolidation, or post autologous stem cell transplant day plus 100, 6 months after maintenance and end of maintenance. MRD was assessed in all of the above, regardless of the serological response, and all the adverse events were graded as per the CTCA latest version. So, because of the COVID pandemic, there were a lot of hiccups, because during the pandemic itself, almost 70 patients were on carfilzomib maintenance, and the treatment delays were there was unseeable treatment delays because of the ongoing lockdown and multiple logistic issues during the COVID pandemic. So the treatment, the research group was pragmatic enough. They allowed 14 weeks of treatment delay during the COVID pandemic. And after 12 months of maintenance, the treatment could be stopped at the discretion of investigators, and the dose modification, step-up doses if there were more than 4 weeks of break, and with regards to adverse events. The adverse events during this trial was particularly to note was there were some patients who were having thrombotic microangiopathy. So the doses were reduced if the patients had subsequent thrombotic microangiopathy, or whether there was a break in the protocol, and if the break was more than 4 weeks. The patients were reintroduced with a dose of 20 milligram per meter square, and subsequently the doses were hiked up to the trial doses. Those withdrawing from the trial was also followed up for the collection of outcome data, so that the trial results are not obscured because of the withdrawal of the patients. So outcomes were measured, and the primary outcomes being proportion of patients with at least VGPR post-induction, and the difference in the progression-free rate at 2 years from randomization. The secondary outcomes which were assessed is the disease response and the MRD response at each time point. The time points, as we had discussed earlier, the time until second progression or death, the overall survival, that is from registration, randomization until death to any cause, and toxicity, and the quality of life. So the statistical analysis, the sample size was calculated using a Ahern single phase 2 design. The total number of patients which had which were recruited was 281 to have a minimal statistical significance. The statistical significance, according to this single phase 2 design, was minimum number required was 233. The efficacy outcomes were analyzed in the intention to treat analysis method. The progression-free survival and the overall survival was based on the Kaplan and Mayer method. The p-values was based on p-values for comparison between the treatment groups was analyzed using the Cox regression value analysis for survival outcomes. Response rates using the chi-square test. The sensitivity analysis excluding patients whose maintenance was delayed due to COVID pandemic performed on the primary progression-free survival outcome. So these were the statistical analysis, and the safety data for all those patients who received at least 1 dose of any form of the study drug. They were all included in the safety data. It was the analysis was performed using the STATA version 16.1. So these were the demographic data. Here we can see the median age was 59 years, and there was a male predominance of 59% of the patients were being males and females being 41%. And the ethnicity predominantly it was white because it was done across the UK, and the Black population was 17%, Asian origin was 8%, and the mixed race was 2%. The other thing to note is that the performance status in this trial, it was predominantly the patients who reported were of having very good performance status as per the inclusion criteria for the trial. And the other thing to notice is most of the patients, predominantly around the 80% of patients was between ISS stage 1 and 2. And there were no high risk, predominantly the patients, the genetic risk profile was in the standard risk category. High risk category was very less, it was less than 20%. So the RISS stages predominantly being RISS 2 and RISS 1. RISS 3 was only 10% of the patients who were in this trial. So Based on the myeloma type, the secretory patterns, single paraprotein was expressed in KCD induction arm in 80%. In consolidation arm, it was 72% and 85%. The response to induction. So here we can see the KCD induction induced response, that is more than VGPR response was induced in 58%, followed by the consolidation arm. Here we can see the KCD group had 69% and the HSCT group was 69%. The MRD negativity responses were almost equal. So the results, what are the primary endpoints? The 43 of the first 53 patients have at least a VGPR after induction, which was revised to 37, that is 70% of the first 53 patients after the central review. The proportion of patients who had at least a very good partial response after induction therapy in the entire intention to treat population was 57.7%. The overall response rate, that is at least a partial response, was seen in around 86% of patients, which is quite good. And around 23% of patients were MRD negative. So post randomization, the HSCT group outscored the KCD group in terms of MRD negativity. That is 48% was MRD negative as compared to 33% in the KCD group with a significant statistical p-value. So let's come to the progression-free survival between these two arms. The median PFS was 38.1 months from registration to endpoint. From randomization, 42.4 months for the HSCT and 33.8 months for the KCD arm. So the 2-year PFS, if we overall analyze, it was 75% for the autologous stem cell arm as compared to 68% in the KCD arm. So the criteria for non-inferiority was set at 10%. It was not met. However, the non-inferiority was just exceeded by 1.5%. 11.5% was the analysis which was made out of this KCD consolidation non-inferiority as compared to the autologous stem cell transplantation arm. So coming to the adverse events during this trial, as we had known, the carfilzomib was dosed at very high, that is the dose was very high as compared to the conventional listing. So here the dose used was 56 mg per meter square. So the induction arm, the most common side effects during the induction was infections. So other grade 3 adverse events being lymphocytopenia. The infections being in induction, it was 18%, and in consolidation, it was 16%. And lymphocytopenia was observed in 26% of the patients as compared to 14%, which was seen in consolidation with carfilzomib. In the carfilzomib maintenance arm, the main issue was hypertension was there, and there were multiple issues of lung infections and cytopenias. So the cytopenias, as we had discussed earlier, the infections were 16% in the KCD maintenance arm as compared to 25% in the stem cell transplantation arm, and the hypertension being 21% as compared to 23% in the stem cell transplant arm. So the treatment emergent deaths which occurred during the induction phase was just 2%. That was 4 patients died while receiving induction treatment, 3 from infection and 1 from a cardiac event. There was 1 patient who had renal failure. He had withdrawn from therapy and progressively he developed renal failure. In the stem cell transplantation arm, 2 patients had expired, 1 with infection and 1 had a solid malignancy in the form of an esophageal malignancy. So this is the treatment adverse effect arm. I'm really sorry, the slide is slightly crowded, but as we had discussed earlier, it is predominantly lymphocytopenia, and there was some around 1% of patients suffered thrombotic microangiopathy. The cardiac events were also very minimal in this trial, followed by lymphocyte count, which was predominantly decreased lymphocytopenia, as we had explained earlier, 26% in the induction and 14% in the consolidation arm. So the KCD induction, the conclusions was the upfront autologous stem cell transplantation should remain the treatment of newly diagnosed multiple myeloma cases. Deferred autologous stem cell transplant in some patients subgroup should be investigated in large prospective trials. So the thing is that what I could make out of this thing is, despite having carfilzomib as the upfront induction arm, the autologous stem cell transplantation still remains the standard of care with this newer modality of therapy. However, the autologous transplantation can be deferred in some patients. That is, again, totally dependent on the MRD negativity rates post-induction. So it should be analyzed in a large prospective trial before coming to any conclusions. So the critical appraisal for this study is was the title interesting? Yes, it was interesting. And abstract, will the conclusions likely to be useful to you in your area of clinical practice? Yes, it is. The settings in the material methods are similar to our own settings. It was yes. And is there a clear-cut specific research question? Yes, it was there. So was it feasible for the authors to study this question given there was technical expertise and available facilities? Yes. The research question had some element of novelty. Yes, it was novel because carfilzomib was used. Earlier, all the induction regimes were predominantly based on lenalidomide as well as that is Velcade bortezomib based induction was there. Here, non-IMiD based induction was used. Second generation PI was used, that is carfilzomib was used. The authors made a mention of actual, yes, they had made a mention of actual study population. The sampling method has been clearly described in this study. The mention of all potential confounding factors has also been made. Though there was no information bias as it was a 1:1 randomization based on a computer algorithm. So the gate frame, the Picot analysis, participants of a total of 281. The exposure group was 109. The comparison group was 109. It was 1:1 randomization. Out of 218, it was equally divided between the two groups. So the outcome which was measured was the KCD MRD negativity was 30.3% as compared to stem cell transplantation arm, which was nearly 50%. That is 47.7% of the patients were MRD negative. So this again underlines the importance of stem cell transplantation despite having a second generation PA as the induction regime. So the duration of the study was June 2015 to July 2019. That is depicted by the T. So assessing the study bias, the Rambo acronym, as we all know, R is for recruitment, A is for allocation, M is for maintenance, and B is for blinding, and O is for objective measurement. So recruitment, the study setting and the eligibility criteria was well described. The participants representative of eligible population, yes. The prognostic and the risk profile appropriate to study question was yes. And the randomization process was described. It was based on a single phase 2 study platform. And the randomization process was again a computer-driven algorithm, which was adequately mentioned in the journal. So the allocation was N281. That is the number, total number was 281 who were eligible for trial, who were meeting the inclusion criteria. And 218 were randomly assigned, and 1:1 randomization had occurred to the 109 to the KCD arm, and stem cell transplantation arm had 109. So there was good maintenance. The participants and the investigators were not blind to the exposure. It was an open label trial. The compliance was high and similar in the exposure group and the CG group. It was moderate and similar. There was completeness of follow-up despite the COVID pandemic. There was complete follow-up, and there was a pragmatic approach by the group so that they had allowed timelines to be increased and the dose modifications, which was important because of the side effect profile which occurred during the trial. So the measurement outcomes were completely blinded. Authors had reviewed all the results. So what are the strengths of the study? The funding agency at any point of time did not interfere during any stages of the study. There was no bias in randomization. The intention to treat analysis also helped to assess the real world scenario of this protocol. There was pragmatic approach during the COVID pandemic because it was, as we had discussed earlier, there were around 70 patients once after the onset of pandemic who were on the carfilzomib maintenance arm. So they had allowed 14 weeks, that is more than 3 months of break to basically to decrease the footfall at the trial center and to protect the patients from the COVID novel coronavirus 19 infection, because as we had known, we had lost many of the patients during the COVID-19 pandemic. The hematology patients were particularly susceptible to this infection. So they had a pragmatic approach with regards to the treatment delays, the dosing schedules without affecting the results. So what were the limitations of this study? Superiority of the autologous stem cell transplantation arm could not be commented because of the non-inferiority study design. The non-inferiority study design was again the trial cutoff was 10%, which was based because at any point of time, even the patients on KCD consolidation fails, they can move up to the autologous stem cell transplant arm. So that was the basis of using a non-inferiority cutoff of 10%. In this study, the non-inferiority results, what we had arrived at was 11.5%. That was just slightly above. So it was not analyzed to, it was not powered to analyze the non-inferiority in subgroup analysis. The transplant-related events were not reported as it was the standard of care, and there was no direct comparison possible during this thing. There were many patients who had withdrawn during the maintenance despite the the research group allowing in subsequent substantial treatment breaks, even up to 14 weeks of treatment breaks were allowed for this patients who were on carfilzomib maintenance. So I will like to discuss what is the applicability in Indian scenario. So the Indian scenario, financial toxicity, to be very frank, we cannot sustain this prolonged course of carfilzomib, especially in a non-government setup, which is a non-profit organization setup. The patients will not be able to afford this longer doses of carfilzomib, because induction followed by 18 cycles of carfilzomib maintenance. In between, we had patients who were on stem cell transplantation also. So the financial toxicity for this particular study is quite high if we compare to the Indian setting, especially where there is not many of the clinical trials which is going on. And the higher doses of carfilzomib, because the dose as we had described in this trial, it was 56 mg per meter square as compared to 27 mg per meter square in the conventional treatment protocols using carfilzomib. It leads to cardiac events, cytopenias, and recurrent infection. The infection rates, which is described in the study, that overall rates were nearly 1/3 of the patients had infections during induction. So India being like a LMIC country, so the rate of infections I anticipate to be more higher with carfilzomib induction. So it will lead to significant morbidity and mortality as compared to this trial data. So the other issue was lenalidomide. The lenalidomide in the UK, it is quite costly. So that is the reason why they wanted to try out a version of trial without IMiD. So this was the basis of giving KCD induction. So carfilzomib, cyclophosphamide, and dexamethasone. Here in India, we have multiple generic versions of lenalidomide available, and our patients, most of them tolerate, like we have grade 1 and grade 2 cytopenias. Accordingly, we can dial down the dose or dial up the dose based on the tolerance of the patient and the maintenance post autologous stem cell transplantation. Many of the patients, they carry on with it, and there is not much of financial toxicity with this lenalidomide because of the availability of generic versions, which is in India. So I want to conclude that myeloma is not a 100-yard sprint disease anymore. It's a marathon. So it is better to run a 10-minute a mile rather than run all the 26 miles than to get exhausted and last only 5 minutes. So ever-growing arsenal of newer agents, especially we have seen anti-CD38 monoclonal antibodies with, like as daratumab, they have increased the depth of the response. That is, as we had discussed earlier, the surrogate for any PFS is MRD negativity. So ASCT can be moved down the pecking order, but again, it should be restricted to a particular subset of patients where the MRD negativity can be documented and which is through a certified lab. So again, I just want to conclude. So as the dictum of medicine also says, one size doesn't fit all. MRD guided treatment, tailored treatment is going to be the future for myeloma in the coming days. So I've finished my journal club, sir. So these were the conclusions.
Thank you, Ranjit. It was very nicely put across, and your Picot and Rambo analysis was great. Now, first, I would like to invite Dr. Amit to give his comments on the article. Your critical comments, please, sir, and your agreements and disagreements with the speaker.
Yeah, thanks very much, Dr. Ranjit and Dr. Uday. That was a wonderful presentation. So I suppose I thought about this paper from a number of aspects. One is what is the role of carfilzomib in induction therapy or in frontline therapy? I mean, there's a number of now KRD regimens, KRD Daro regimens, which have been trialed, showing pretty high rates of MRD negativity even without transplantation in induction therapy. But really, we don't have a definitive clinical trial to say that it is better than VRD, which is still the gold standard, as of today, probably will change fairly soon with the addition of the anti-CD38 antibodies. But we still don't have definitive evidence that anything is better than VRD, both from an efficacy or, and as brought up, a toxicity perspective. Again, I think VRD is a lot easier to deliver than, or Velcade or bortezomib is a lot easier to deliver than carfilzomib. And carfilzomib has its own toxicity profile, as mentioned, particularly from the cardiovascular effects. There is some, I think, thromboembolism is an issue, but that's not so much talked about, and hypertension and a whole range of issues. The other aspect is the dose that was used when the study was devised was the 56 milligram per meter square twice a week. I think it was probably just before the results of the ARROW study came out, which showed that 70 milligram per meter square once a week is equivalent to 56 milligram per meter square twice a week, and much better to deliver from coming to the hospital to get a treatment twice a week is always an issue for patients to get into treatment fatigue very soon if you keep bringing them to hospital very frequently. So at least in my practice, I've pretty much moved away from the twice weekly carfilzomib regimen very early on. It's pretty much almost as soon as the results of that ARROW study came through. And I think patients find it much better in terms of tolerability. So that's those are my thoughts around carfilzomib. Now the addition of cyclophosphamide to the regimen is reasonably well tolerated, but does probably add a little bit to the cytopenias. The interesting is the MRD negativity achieved, or the rates of MRD negativity achieved with transplantation is close to 50%. So that's, I suppose, equivalent to what you would see with VRD and a transplant, not as much as DVRD and transplant, which is above 60%, but and this is again at the risk of cross-trial comparison, but it's still pretty good. And so if for any reason, I mean, there are patients who can't tolerate Revlimid because of toxicities, rashes, and so on and so forth. There's a small group of patients who can't tolerate lenalidomide, and so I think changing to cyclophosphamide in that setting is a very worthwhile exercise. And if a patient for whatever reason can't tolerate bortezomib neuropathy, so then I think then in that setting, using the alternative proteasome inhibitor with carfilzomib to get the deepest possible response. I think this trial provides a lot of options, evidence-based for a lot of options around induction therapy. Now, where I would disagree in terms of the conclusions about transplant, I am maybe rightly or wrongly, still a very much a believer in the role of high-dose melphalan in upfront treatment of myeloma. Every study for the last 30 years where transplant has been compared against a non-transplant based strategy has shown deeper responses in the transplant arm. Even in the quadruplet era, the MRD negativity is significantly better in the transplant arms as compared to the non-transplant arms. So I think, and given the question of financial toxicity, now it's come to the point that transplant is the cheaper option for treatment as compared to long-term maintenance therapy with whatever regimen is used. So if as we are moving towards an era where MRD-directed therapy is going to be it's likely that MRD-directed therapy is going to be the new treatment paradigm, then we use the regimen that is most likely to achieve that outcome. So addition of transplant is going to I think still be useful in that setting. So and the other aspect is in terms of the issue around delayed transplantation or doing it as in second line therapy or at relapse. What I have not seen good data to actually show how many people actually get to a second transplant. I mean, my thoughts are always, I think, to some respects, colored by the AML data which showed for deferred allograft, less than 50% of patients actually made it to a second allograft, even if they were even if it was indicated. So I suspect that a large number of patients for whom a deferred autograft is planned never get to it for a whole bunch of reasons. So so I would caution against putting away the autograft, at least in currently with our currently available therapies. So that's my take on the autograft question. I'm still quite a strong proponent or an advocate for early autografts in newly diagnosed fit patients with myeloma. And then I suppose when it comes to the maintenance question, again, giving an IV drug in maintenance for 18 cycles, I mean, they had dropped the intensity to once a week, is still difficult. So as compared to the oral alternative of lenalidomide, which is less expensive now with the generic versions available, and probably better tolerate. But I suppose the question is, if there are a group of patients who can't tolerate lenalidomide, and there are the other questions around second primary malignancies with lenalidomide, which are more and more becoming an issue. I suppose that to have the alternative of carfilzomib maintenance is useful in that setting. But at least in a few patients in whom I've used carfilzomib maintenance, treatment fatigue sets in very, very quickly. Usually they get down to, now there's no evidence for this, but at least in clinical practice, I have used it fortnightly and occasionally even once a month. So so that's the issue around maintenance. So I think the other issue is also, and I forgot to mention around that transplant issue, that definitely if it is high-risk cytogenetics, again, that is one group of patients who definitely should have a high-dose melphalan autograft, at least one. And there are some people make the arguments for tandem in that setting as well. So, and in this patient cohort had relatively low numbers of high-risk patients, so that could have impacted overall on the outcomes, because those numbers were a little bit low. Now, when it comes to maintenance therapy in the high-risk cytogenetics, I think the myeloma 11 study showed that lenalidomide maintenance is still very beneficial in that high-risk cytogenetic subgroup. So I think the previous thoughts that a proteasome inhibitor would be better as maintenance in the high-risk cytogenetic subgroup, there's no real definitive evidence to say that proteasome inhibitor should be used. So I think those were my that was my take on the study. It's useful to provide alternatives to what is current standard of care, but I think the field is probably moving on from some of the questions that it's asked. That's my take on this.
Thank you, sir. So I will request if Nirav, can I share my screen?
Yes, sir.
Can you see the screen, full screen?
Yeah, we can see the screens now.
Okay.
Yes.
Yeah. So thank you, Dr. Amit, for your critical comments and for your opinions about the transplant part of it, which I totally agree to, because I also believe strongly that transplant still, despite of whatever has come new, remains to be the backbone for everything. So I will divide my comments into two sections, the article related and the practice related. So in the article related, less than 15% of the patients were high risk group. So the first important question is, can we really extrapolate it to all the myeloma patients? Because the number of people with RISS were very, very low in this particular article. Secondly, they have done an intention to treat, but we need to actually talk about statistically is per protocol good or intention to treat good? Because generally all of us have an opinion that intention to treat analysis are always good because they tells us about even those people who have discontinued because of side effects, etc., etc. But there's one place where intention to treat generally might not be very good. That is when we have a swapping from one arm of the study to another arm of the study. In this particular trial, 18 out of the 63 patients with disease progression after KCD consolidation were reported to have subsequent transplantation. So that means these 18 patients, the survival results, the PFS results, MRD results were combined to the parent KCD arm just because it was an intention to treat analysis. So in such situations, whenever we are swapping from one arm of the study to another arm in a RCT, it's better to go for a per protocol for that particular phase rather than doing an intention to treat. So I really do not agree with the authors as far as the way they have analyzed. They also though have given in the supplement the per protocol values, but even in this particular thing, the overall per protocol also is not a good idea. So it has to be a combination for different phases of the study by using per protocol in certain phases, intention to treat in certain phases, or for certain group of results, they need to give it differently. So it has to be a combination or a hybrid rather than using any particular thing. Now, the study dates are from 2015 to July 2019. And the authors say that they had to discontinue a huge part of it because of COVID. But I really don't understand, was the recruitment the last phase of the study, because out of the 4 years, because the median follow-up was only around 40 months. So if there was a median follow-up of that much, then why should COVID lead to so much of impact? And particularly for discontinuing, adjusting results, etc. Again, needs to be explained. The authors needs to explain that. And we need to have an enrollment chart of was it even throughout the period or was it mainly to the end of the study period? Now, only 55 and 59 from either arm completed carfilzomib maintenance. Though they say COVID led to only 10% of this problem. So out of 109, if there was a 59 people who had completed a COVID carfilzomib maintenance, out of 50 who did not complete maintenance, only 17 were because of COVID. What happened to the rest? That really shows what Dr. Amit highlighted about the difficulty of maintaining a patient on carfilzomib maintenance because of multiple issues. It could be because of progression, disease, etc., which Dr. Ranjit had highlighted. But it's an important fact to show that carfilzomib maintenance might not be a really great idea. Lastly, as far as the article related is concerned, they clearly say that they have excluded patients who had delayed maintenance due to COVID, but again went ahead and said that they did an ITT. So again, there was a confusion on that part, which they need to explain better. The authors would have done a better job by explaining these things better. Now, coming to the practice related things. Now, few points which were already highlighted by Dr. Amit, which I would like to reiterate. Does anyone use KCD as a first line therapy still in either India or Australia or Bangladesh? I'll take opinions at the end of this slide. I have only one slide to show. So, but KCD as a first line, at least in the practice, which I have seen a very, very low percentage as a first line therapy. Now, this was anyway, again, highlighted once a week versus twice a week. So most of us nowadays resort to once a week therapy rather than twice a week. So again, that was one thing. Lack of R in the induction regimens with so much of data showing that inclusion of IMiD, particularly lenalidomide, in otherwise fit patients, as in this particular study, who do not have renal dysfunction or contraindication for R is questionable on today's date. If they would have done the same study with KRD rather than KCD and shown that whether KRD consolidation versus transplant, was it of any benefit or not, that would have been a better study rather than they using a combination of KCD for this particular study design and for this particular aim, where they wanted to say that HSCT is relevant or not in the presence of giving consolidation with few more cycles. So for that, a KRD would have been a better choice rather than KCD. Lastly, again, this point was already covered. IV drug for maintenance, as far as patients are concerned, it's extremely painful. Their cost, their billings, various other things increase. So maybe a subcutaneous or an oral drug would have been a great option. So these were my comments as far as the thing was concerned. So hello. So the thing is, with this, I would like to complete my comments as far as the article is concerned. But I would like to take opinion of, we have
Because
Reena
I
ma'am,
think it
Pankaj
should
sir,
come. That's
Reena
why
Nair,
they think, okay, I'm only saying.
and
Sure.
Pankaj sir on the group to comment about the uh, practice of KCD as a first line therapy and K once a week versus twice a week. So can I have comments from Pankaj sir and Reena ma'am for the Indian practice? Then I will take opinion of Dr. Amit that how many patients receive this combination for extrapolating this article results to our daily practice, and then from Dr. Mohiddin Khan. So over to you, Pankaj sir, your opinion about KCD as first line therapy and K maintenance.
Yeah, thank you, Uday. So the first question which I have is a little clarification. The trial ended in July 2019, and the COVID started in March 2020. So maybe the trial enrollment was over, and it was probably those patients who were on maintenance therapy. Probably they were affected by the COVID, and not the initial recruitment of the patients. So is that true, Ranjit?
Yes, sir, that's true. That's true. It's only for the maintenance part because the enrollment finished in 19. Even that also, when we look at the median and maintenance, it was not fully fitting in if we draw a chronological graph. So until unless they have done a 90% or 70%, more than 70% enrollment in the last 1 year in 2019. Otherwise, it should not have affected actually grossly.
So
Yeah.
when the lockdown was declared in the UK, that was on 24th of March 2020, sir. So at that point of time, 70 patients in this trial were on carfilzomib maintenance, sir. So the number was 70 because I had gone down and I had a background to this. So 70 patients were on carfilzomib. So this indirectly indicates that the majority of the recruitment which was happened, it happened towards the latter part of the study rather than the proximal part of the study. So that was the reason why it spilled into this COVID during. And the last day of data cutoff which they were taken was 7th of July 2022 prior to publishing this article. So the 70 patients were during this lockdown period which had, so they were very pragmatic. The research group, they allowed treatment breaks, like around 14 weeks was allowed as compared to 4 weeks during the initial phase, and the doses were modified. Especially patients who were having a very prolonged break, they again reintroduced carfilzomib with a dose of 20 mg per meter square and subsequently hiking up in the next cycle. So the applicability part, especially the recruitment in my this thing, it would have happened in the second half of the study, sir. So that is the reason, because the median follow-up was just around 41 months. Sir.
Right. So I think the purpose the trial was done in UK is because the lenalidomide is not approved, and they wanted to see what is the effect of carfilzomib. And we already have a FORTE trial which is published, which is comparing KCD with KCD consolidation and maintenance. Again, there are two arms versus KRD and continuous KRD versus the KCD followed by auto transplant. So I think the purpose they were trying to do was putting carfilzomib as frontline therapy, and maybe by the I would say by the company, but I don't think so that they have been able to successfully do this. Successfully been able to get this result that carfilzomib can be used upfront as compared to bortezomib. The third thing is when you compare with India, then obviously in Indian population we have almost 50% of patients who are in ISS 3 or are ISS 3 stage rather than in RSS stage 1 and 2. So the risk stratification was obviously different than if you try to compare with India. And since myeloma is a continuous evolving field, so they took 1Q as the standard risk stratification, whereas now we know 1Q is come as high risk cytogenetics. And obviously, Uday has highlighted about the dosages part and the intravenous and so many other issues. I actually would like to know that the patients who achieved MRD negative with KCD, and what happened to those patients if they continued with KCD versus if they underwent transplants. So I don't know whether they have done the analysis or not, because what we believe right now is that somebody who achieves an MRD negative status, irrespective of the treatment, they all do equal on a long-term basis. So that is one of my questions. Thank you so much.
Sir,
Thank you.
sir,
Yeah, Ranjit, please.
So can I ask Dr. Pankaj one? This thing was lenalidomide, sir. So like I was just going through what was the price of lenalidomide in the UK. So it is per patient. If you want to continue the patient on lenalidomide for a year, so that works out around 54 lakhs, sir, in Indian rupees. So that is 52,400 pounds. So Revlimid is quite costly. So basically the research group wanted to move away from Revlimid because it was initially not approved by the NICE group for induction in the UK, sir. So the costly thing, they wanted to move away from a costly drug to a slightly less costly drug. So that was the basis. I think they went ahead with this study, sir, because to maintain the patient on such a long this thing was like the financial toxicity for Revlimid in the UK was quite high as compared to carfilzomib, sir. So
I agree, but there is enough data now that all induction therapies should have a PI and an IMiD combination. Is much better than using a single novel agent in this scenario. But anyway, I agree that when they started with the trial, at that time the information was not available. And in hindsight, we say that irrespective of the cost, a combination of IMiD and proteasome inhibitors is the standard of therapy currently.
yes, sir, totally agree on that.
Yeah.
Thank
Thank
Dr.
you.
Pankaj and Dr. Ranjit for their comments. So, because we are moving behind schedule, so I would like to now invite Dr. Mohiuddin Khan. Now, the reason of we having him here is actually, if you all listen to me, you'd be really startled. Sir is the founder of hematology practice in Bangladesh. He has created 10 medical institutions with hematology departments with 272 posts in Bangladesh. He is the pioneer who established BMT centers for the first time in Bangladesh, that was in 2014. Under his leadership, multiple transplants have taken place, and he has also been a pioneer for the convalescent plasma therapy in Bangladesh. He has been a member of various parts of hematology in Bangladesh, starting from thalassemia services to blood banking services, to transplant services, to oncology services in Bangladesh. So we are very happy to have you here along with us. We would like to give your comments about myeloma practice in Bangladesh, and as a friendly neighboring country, how can we take the collaboration together forward? Over to you, sir.
Thank you, Dr. Arun, for compliments, and also thanks to Ranjit for beautiful presentation, excellent presentation. In Bangladesh, suppose we practice first-line practice with RVD protocol. In my 4 years data, in my personal OPD patient, out of 60 patients, we've seen that relatively earlier in comparison to Western country, multiple myeloma, that is less than or 60 years age group, out of 60 patients, 30 patients are less than having 60 years age. And so, and another important observation is that about 44% patient at presentation having renal impairment. So in those who have not renal impairment, we are use RBD protocol, and those having renal impairment, we go for Cybor D protocol. As Carfilzomib is not available in our country, usually we practice in relapse case, and I have some experience to use few patient. KRD or KCD protocol. As maintenance, we are using lenalidomide-based protocol mostly. One thing is that because a good number of patients having renal impairment, and it is some study showed that the carfilzomib is better outcome in comparison with bortezomib. So I think that if we practice this protocol, then outcome is better. And one thing is that financial toxicity at the same time, drug toxicity is an important issue, no doubt. So in short, this is my opinion.
Sir, we would also want you to comment about improving the practices or the knowledge or the awareness of plasma cell dyscrasia in Bangladesh. And what do you think is the weakest link or the most essential aspect as far as improving myeloma care in Bangladesh is concerned? And how can we tackle that with a mutual collaboration?
Yeah, well, we can definitely we can do awareness by different this type of discussion. And in our there is a hematologist, in fact, deal the myeloma patient, and sometimes most patients come in late because it is a referral system is not very weak in our country. Sometimes patients come directly, or most of the patients come from medicine consultant, internist, and or orthopedics or like that. So and many patients cannot continue the treatment. And my observation is only 20% patient can afford or agree for transplant, autologous bone marrow transplant. Out of 52 transplant I have done in my tenure in the Dhaka Medical College Hospital, among them 13 patients I have done with multiple myeloma, and others for total out of 47 autologous and 5 allogeneic bone marrow transplantations. Definitely, we share the knowledge, and new protocol, new drug available is important issue, and follow-up also a important issue. Thank you.
Thank you, sir. Thanks a lot for the insights of myeloma practice in Bangladesh. And we will continue discussions with you, both online, offline with you. And we would like that you will try to take our neighbors along with us as far as the journey of the plasma cell dyscrasia is concerned. And as a group, we would love to definitely collaborate with the Bangladesh Hematology Society and the various other organizations you are a member of and president of to take it further. Thank you, sir. Thank you for being part of the discussion today. Now, I would like to hand over the stage to Arun for taking it further for the general scan and for the quiz. Thank you, Arun. Over to you.
Thank you, Uday. Nirav, can you please share the slides? So this is my honor to discuss the Eagle Eye competition, and we discuss about the best commentary we received on a journal scan article we received. So the topic for this month was about the mass spectrometry versus immunofixation for treatment monitoring in myeloma. And just for the people who have logged in for the first time, just to introduce the process through which we go in. The next slide. So we go in first with the next slide, choosing an article first about myeloma, which is recently published in a peer-reviewed journal, and then we share that link with you. You're supposed to critically analyze that and send a commentary to us before the due date. The important point here is anyone can participate, anyone with an interest in plasma cell dyscrasia, irrespective of the non-nucleum or the degrees could participate if he has an interest in myeloma. And we shared the commentary with the reviewers, and we have somebody who was chosen to present his review as the Eagle Eye winner. In addition to the credit hours and the vouchers you get for the prize, definitely you're presenting your journal scan in front of an august audience here. The next slide. So the purpose, if I have to sum it up, is more than critical appraisal is about refining the art of scanning an article. We will improve upon the skills about writing letters to editors. And like what I said, you present in front of an august national and international audience. And for some of us, it makes it a matter of inter-institutional competition. And we have winners from all across India, spanning different centers in the last few months. So how do we analyze? The next slide. The most important point is we have 8 to 9 variables on which we analyze what is being submitted, but my submission is always stick to the word limit and concentrate on the methodology and statistics. And it is my privilege to announce the winner for the best commentary submitted this month. The next slide. So he's Dr. Ramesh Balasubramanian. He's an associate consultant from a center in Madurai. Congratulations. And we will rather play what he has to say on this particular topic in this forum. Nirav, could you please share the screen and play the video?
Good evening, teachers, dear colleagues and friends. Journal scan for today is an article published in Blood Advances, Mass Spectrometry versus Immunofixation for Treatment Monitoring in Multiple Myeloma. So, treatment monitoring in multiple myeloma is mainly based on identifying and quantifying the M protein by electrophoresis and immunofixation in serum and urine samples. The current use of highly active therapies has significantly increased the proportion of patients in whom the M protein becomes undetectable by IFE during and after treatment. The recent data from the PETIVA trial showed that the standard response criteria were no longer prognostically meaningful after consolidation. So there is a need to adjust the sensitivity of the techniques used for the response assessment to the current treatment efficacy. So coming to methodology, the first 223 patients out of the 458 newly diagnosed transplant eligible multiple myeloma patients in the PETIMA trial were included. This was an open label phase 3 trial. All the patients were administered 6 cycles of bortezomib, lenalidomide, dexamethasone as induction, followed by autologous transplant, which was followed by 2 cycles of consolidation with bortezomib, lenalidomide, dexamethasone. Serum samples of all the patients were analyzed at baseline and after induction, transplant, and consolidation. The M protein in the serum was assessed in parallel by IFE and mass spectrometry using the Extend system. The 12 charge state was used for interpretation. The mass to charge ratio of the M protein was identified in the baseline sample and it was used as a patient-specific tumor marker in the follow-up. Pooled normal serum was used as a negative control. First, the immunoglobulins are purified through the paramagnetic beads, which were coated with the polyclonal sheath antibodies specific for the human immunoglobulins, heavy chain as well as light chains. Then analysis was done with the matrix-resistant laser desorption or ionization time of flight device, and a mass spectra from 5,000 to 32,000 mass to charge ratio were collected. Spectra were reviewed using the in-house software. The +2 charge state was used for interpretation. The mass to charge ratio of the M protein was identified in the baseline sample and was used as a patient-specific tumor marker in the subsequent ones. The statistical analysis were performed using the GraphPad Prism version 9. PFS was defined as the time from the sample collection until disease progression or death from any cause. The Kaplan-Meier graphs were constructed and the two-sided log rank test was done. Coming to the results, this is the patient characteristic at baseline. The median age was 58 years and almost equal sex ratio, and one half of the patient had high-risk cytogenetics. And IFE was done in all patients along with MS. Comparing the M proteins by IFE and mass spectrometry, here in dark green is a total of 24 patients in which mass spectrometry has identified an additional minor peak in all these 24 patients, whereas in IFE could identify only the major peak. And the total of 4 patients denoted in yellow are deemed as non-secretory by IFE, whereas mass spectrometry could identify a monoclonal protein in these patients. The patients in light blue, here total of 5 patients, only the free light chain were identified by IFE, whereas the heavy chain component was also picked up by the mass spectrometry. Here in pink, the total of 5 patients, there was total discordance. And this light green, the 2 patients where only light chains were identified by mass spectrometry, whereas by IFE, the heavy chain comment was also picked up. But these 2 patients denoted light green, when they were followed up for 5 years, there was no significant progression in them. The total of 24 patients in dark green, in which the additional minor peak was identified by the mass spectrometry. 12 cases were followed up, of which 6 cases, both major as well as the minor peak, they persisted. In 4 cases, only the main peak remained in follow-up, whereas in 2 cases, the minor peak only persisted as a marker of disease. Whether these minor peaks, they could represent the additional tumor tools, further studies are needed to ascertain this. So this graph shows the comparison of M protein detection by IFE and mass spectrometry. Here in dark red is the both positive, whereas the dark blue is both negative. So the total concordance of approximately 83%. Whereas in dark green, you can see approximately 12 to 15% of cases in which the M protein was picked up only by the mass spectrometry. Whereas in the least minimal of approximately 3 to 4%, the cases were identified only by IFE, and which were negative by mass spectrometry. When these patients were followed up for 5 years, there was no progression at all. So this Kaplan-Meier graph shows clearly that there is a significant difference in the survival of IFE negative patients denoted in blue versus IFE positive patients post-induction and post-autologous transplant. Whereas post-consolidation, there is a merge in both the graphs, especially after 3 years. So this is not IFE is not significantly able to differentiate the progression survival whether it is positive or negative. Whereas with mass spectrometry, there is a clear demarcation the survival of 5-year PFS between the mass spectrometry positive and negative cases. So combining both results together, both IFE and mass spectrometry negative patients denoted by the red graph and the pink graph where only the mass spectrometry could pick up a M protein, there is a significant difference in the progression-free survival. So IFE was able to differentiate the progression-free survival after induction, after transplant, but not after consolidation. Whereas mass spectrometry retained the clinical value at all the 3 set points, and it was able to segregate the IFE negative patients into 2 groups of different PFS. So to conclude, mass spectrometry is superior to IFE in picking up a minor M protein. So this translates into meaningful clinical value in terms of PFS. Further studies comparing the results of mass spectrometry with bone marrow-based MRD methods such as next generation flow and next generation sequencing are warranted. So coming to the critical analysis, mass spectrometry is superior to IFE in terms of sensitivity. There is no doubt in it. Especially in patients treated with monoclonal antibodies like daratumumab, mass spectrometry could eliminate the false positive results obtained with the IFE. So these are the International Myeloma Working Group recommendations regarding mass spectrometry. They tell that this could be used for clinical assessing the patient and also for assessing the patients on clinical trials, especially for distinguishing therapeutic antibodies from the endogenous M proteins. So using mass spectrometry method could lead to low rate of CR, and therefore cross comparison CR rates in trials done in different time points cannot be done. 2 practically relevant points need to be discussed here. For a low middle income country like us, affordability and availability are the 2 main tools in choosing any diagnostic test. So IFE is economical when compared to mass spectrometry in terms of availability and affordability. And for a disease like myeloma, where you need to assess the treatment response at different time points, definitely IFE will be cheaper when compared to mass spectrometry. And there is a great technical expertise needed in establishing and standardizing the mass spectrometry. We just don't treat all patients of myeloma just by a single M peak identification by IFE. We follow the patients serially and take a decision whether to treat at that point or not. So wait and watch approach can still be followed in a set of asymptomatic patients, at least with standard risk. Median time point between biochemical and clinical relapse is 5 to 6 months, but only 1/4 of the patients biochemical relapse do not show symptomatic progression after 2 years. So chasing behind a deeper response by identifying a minute M protein by mass spectrometry and changing the treatment will exhaust the available drugs of myeloma unnecessarily. So to conclude, mass spectrometry is superior to IFE in terms of sensitivity, agreed, but still there is a long way to go in using mass spectrometry into clinical practice like MRD. Thank you.
Thank you, Neera. And I think you all would agree that the last slide beautifully sums it up. mass spectrometry is definitely looking like a panacea in times to come. I would just want one input from Dr. Ahmed, whether in his routine clinical practice, especially at least in the setting when he's using daratumumab, is he using mass spectrometry in the clinical realm, not in the trial realm? Sir, could you please comment on that?
No. I think I don't use mass spectrometry in clinical practice. I think the question is as a more sensitive marker. In my mind, it's what the comparison will be with using either flow-based or molecular MRD in the bone marrow. So I think if in the future this technology is validated in larger scale clinical trials and prospective studies and compared against flow-based and molecular-based MRD, and so it may get away from, then it may become cost-effective and from a practical standpoint be a better test.
Yes, sir. Due to paucity of time, I think we'll move on to the next session. That is the quiz time. That's fun. Nirav, please share your screen. So the rules of engagement have been the same. We have 5 questions here. The 2 on the journal club, which was concluded, the 2 on the journal scan, which was discussed, and 1 on the trivia. And the fastest fingers gets the rewards here. Yeah, the next slide. So the trivia, like I think it looks a bit descriptive, but I think it's a beautiful description of an entity called X in the history in the British Medical Journal way back in 1890 by a pathologist. And he would debut it like to be a fungal organism in tissue sections. He had studied in detail whether it was a syphilitic gamma or a tumor of the dura or the alveolus of the breast. The next slide. So my question to you is, if this is the diagrams what he drew upon on all these sections, you have to identify X for me. Whether it was Russell bodies or a Mott cell or the plasmacytoma or a flame cell to be described for the first time. You have about 30 seconds to answer, and we go by the fastest fingers first. The second question is about identifying the incorrect statement on what was discussed by Dr. Ranjit on the Cardamom trial. So if you have been attentive, I think the answer glares here. We have 4 options here. Kindly go through the options and tell us the incorrect statement. So the next question is again with respect to the trial design of the Cardamom trial. It is regarding the carfilzomib dose and schedule at both phases, the oral cyclophosphamide dose, and whether cyclophosphamide mobilization was a strategy for stem cell harvest, and was dose adjustment done for dexamethasone dose. We move to the next 2 questions on the mass spectrometry data, which was published by Naomi et al. Please go through these 4 options, and you're supposed to identify the incorrect statement with respect to the study results. The last question was a discussion, the speaker had alluded to in his journal scan presentation. This is as per the IMWG recommendations on the use of mass spec by their position statement in 2021. Nothing much has changed from that position statement. So you're supposed to identify the incorrect statement. Thank you all for your participation. While the organizers compile the results and announce the winner, let me move and discuss the answers in a jiffy. The first question was about this trivia and this description of an entity called X. And if you see in the British Medical Journal, I had actually hidden this name. That was William Russell. And if I can have the next slide, please. This was his earliest drawing of the Russell bodies, which we fancy in our slides when we see them. And if you can see in the photomicrograph given here, especially the panel A are inclusions within the nucleus, they would be called correctly the Dutcher bodies, and the one which are cytoplasmic are truly called the Russell bodies of myeloma. The next slide. This was with respect to the incorrect statement on the findings of the Cardamom study. ABD are all correct statement. But as discussed, the non-inferiority margin of 10% was never met, because if you see the lower confidence interval of PFS, it steps on to 11 and 12, and it was definitely not 10. So that was the incorrect statement. The next slide. The next one, next question was about, again, the trial design here. And we should note here that the carfilzomib dose and schedule was preserved in the induction and consolidation, but definitely it was lowered in the maintenance phases. And an important point here, conventionally, we use a cyclophosphamide oral dose of 300 milligrams per meter square in most of the trials and even in our clinical practice. But at least in this study, strangely, they had used a 500 milligram dose, flat dose, maybe to trade off the cytopenias, which would come up with a heavy dose of carfilzomib of 56 milligrams per meter square twice a week. And despite using cyclophosphamide mobilization was allowed during stem cell harvest, and DEXA was definitely reduced to reduce the toxicity somewhere during consolidation. So the incorrect statement was options C. Yeah, the next question. Regarding the mass spec, this is one important blip. Even with the mass spec, identification of IgD and E myelomas are not possible because the mass spec is not standardized for that. So the platform used even in this trial did not pick up IgD and E. That has been a caveat. Even with the IFEs we have to specifically ask for them or suspect them based on the circumstantial evidence we get. The last one. Important point, even in the position statement from the IMWG, who do endorse the MALDI-TOF liquid chromatography systems, it does endorse it in clinical assessment as well, although there are no real takers for it in the real world. But important here is this statement number C, which talks about not to use mass spec for cross comparison of CR rates in trials designs. Definitely that would erroneously result in inferiority data. So the correct answer is C here. Thank you all. Nirav, have we identified the winner here today?
Sir, Dr. Sumit Mirk from TMC Actrec, Mumbai.
So Dr. Sumit is the winner this time, and I think this is not this time he's winning it. I think this is the second or third time he's winning the quiz. Congratulations, Dr. Sumit from Actrec. Yeah, we move on to the next slide. And the next. So we have been meeting every 4th Thursday now, every month. So the next meeting would be on 27th of July. Dr. Niti Munshi would be our international myeloma expert who will join us again on the Indian Standard Time of 5:30 p.m. Before I wind up, let me just express my sincere gratitude. The next slide, please. To members of the IMAGE Scientific Newsletter Subcommittee, Dr. Das, Dr. Joseph John, Dr. Hari Menon, and the support we get from this prodigious national faculty, Dr. Naveen Khatri, Dr. Sudhashiv Du, Dr. Tapan Saikia, Jan Nair, Dr. Reena, Dr. Pankaj, and last but not the least, my sincere gratitude to Dr. Amit Kaur who actually joins up at late into the evening and actually sat through the entire proceedings and gave his valuable comments here. Thank you one and all. And now I hand over the stage to Dr. Uday for his concluding remarks.
Thank you, Dr. Arun. I think we have already overshot time. I'll not take much time, but I would like to thank definitely our experts and the executive committee members who have stayed through the meeting. Dr. Pankaj sir, Dr. Inana ma'am, who is on board now, Dr. Sadashivdu sir, and also we had Dr. Joseph Jones sir till few minutes back. So I thank all of them. And I especially thank Dr. Amit Khote sir for staying awake late night to be a part of this meeting. Thank you, sir. And I also thank Dr. Mohiuddin Khan. So with this, we come to the conclusion of this particular Journal Club. We meet up again after 4 weeks from now. Thank you all.